Good evening and welcome to the July 2025 edition of Glaucoma Australia's live Q&A webinar series, which is proudly brought to you by our long-standing and generous supporters, Glaucos. My name is Val Toswell and I'm one of the patient orthoptist educators here at GA, and I'll be your host for this evening. Before I introduce tonight's guest speaker, I would like to acknowledge the traditional custodians of the lands, skies and seas in which we collectively gather for tonight's event. I pay my respects to our elders past and present, along with their emerging leaders. Tonight's topic is sustainable glaucoma care and home monitoring, presented by Dr. Simon Skalicky. Simon is an Australian glaucoma subspecialist ophthalmologist. He's an associate professor at the University of Melbourne and Royal Victorian Eye and Ear Hospital. Simon is the founder and inventor of Ioni, an Australian software company that provides visual field testing on any computer or tablet. With an astounding 25,000 tests performed and 11 research papers validating a similar accuracy to conventional perimetry machines, Ioni holds promise to improve the usability, accessibility and affordability of perimetry services globally. Simon will be providing an overview of new technologies, new ways of glaucoma monitoring, and steps to make our eye care sustainable in the long term, a pathway that's very dear to us at GA. Thank you, Simon.
Thanks, Val. I will figure out how to share my screen. I did it before, share screen.
It's all in the timing.
It's a real pleasure to be here. I can't see you all there, but I know there's a lot of people in the audience, so I reach out to those that I know and most that I don't. Those that know me know that glaucoma is very dear to my heart, and Glaucoma Australia, and I care a lot about what it's like to have glaucoma. My PhD was in the topic of how glaucoma influences people's quality of life. And so a lot of my thinking and my work has really taken me on this journey of how can we make things better, just a bit easier for our patients, and how can we also reassure them as they go through their journey with glaucoma. So I'd like to talk about home glaucoma monitoring and sustainable glaucoma care. Now, glaucoma is a journey, and it's often a slow journey that begins at normal and ends right at the very end, unfortunately, of blindness. As I said, it's good that it's slow because there are many steps along the way where we can intervene and prevent this. So this is not a, fait accompli. This is a very modifiable journey, and the earlier that we modify, the earlier that we detect, I should say, the better. Glaucoma is not just about eye pressure. Glaucoma is a multifactorial disease, and there's lots of factors that go into it, about blood flow, oxidative stress, neurotoxicity, immune mechanisms. But really, where we are in 2025, the main modifiable risk factors are intraocular pressure and psychological stress. It's interesting. I used to say for years and years, the only thing we could do was lower the pressure. But my good friend, Prof. Tanuj Dada in India, has done a fascinating series of research papers about meditation in glaucoma, showing that it's definitely helpful to lower pressure and prevent glaucoma progression. But most of our treatment, as most of you are aware, focuses around lowering the eye pressure. And glaucoma management is not just about lowering the eye pressure. That's the treatment half. As you all know, monitoring is so important. And monitoring comes in different ways of doing things for different patients in different centers. But it broadly involves checking the pressure, checking the visual field, and imaging the optic nerve, and looking for change over time to guide our management. And that becomes interesting because if this is roughly the model where on average, patients need a pressure check every 6 months, an OCT scan once a year, and a visual field once a year, then the question is, well, where is that done and who's doing it? And these days, collaborative care is so important, and optometry and ophthalmology working together. And that's something that I've personally been a long proponent of, and working with GA. I know GA is right there championing this, that it's a team. We're all in this together, and we all work as a team. And certainly optometrists and ophthalmologists do. Now, remember, as I said, glaucoma is not one disease, but people are not all the same, and everyone is different. And so I need to consider that when I'm treating glaucoma, and I need to think about all these things: pachymetry, which means how thick the cornea is, whether the pressure fluctuates in 24 hours, what the pressure is untreated, what our target pressure is, what the person's life expectancy, what's happening with the other eye, what are some of the comorbidities. These are all the things that go through my mind when I'm seeing my patients with glaucoma. But, it doesn't stop me chatting about, grandchildren and what we're doing on the weekend and where we're traveling to. So it's definitely important to individualize treatment and also get along well with our patients. Now, here's some sobering statistics. Glaucoma is a big problem right now, and it's getting worse. In that today, there are about 80 million people with glaucoma in the world, and that number is going to rise to about 114 million by 2040. And you can see the breakdown here. And most of the rise is happening in Asia, and also a little bit in Africa as well. And those sorts of population centers are kind of really overshadowing the natural rise in other places. And as I'll talk in a second, many parts of Asia and Africa, they are not coping with the current workload. They are missing the vast majority of cases of glaucoma, let alone being able to gear up to deal with this future growth. This is a very sobering statistic. What do these percentages represent? These percentages are the number of people with glaucoma that are undetected. So if you look at our part of the world, 59%, that means that we have only detected around 41% of cases in Oceania. Now in Australia, 50%, we've detected 50% of glaucoma. Now, most of you, just about all of you, are probably thinking, oh my goodness, 50% of glaucoma is undetected in Australia. That's terrible. But that's actually some of the best statistics in the world, because when you go to Africa, only 6% of glaucoma is detected, and in Asia, only 16%. So you see what a big global problem is, that not only is there a lot of glaucoma, but we're not detecting it today, and how are we going to cope with the growing burden in the future? And remember, every glaucoma patient that's undetected is someone silently going blind or losing vision, that if we knew about them, we could do something to stop it. So as I said, sobering stats. Now, sustainable is an interesting word. And I think when we throw around the word sustainable, we're kind of thinking of carbon footprint. But I would argue that it means lots of things, actually. If you take it out of sort of the modern, political context, sustainable just means it can keep going and going and going. So it's not just about carbon footprint. It's also about cost, and it's also about workforce. But let's talk about carbon footprint for a second. And this is research done by my friend and colleague, Jessie Gale in New Zealand. And Jessie is a keen collaborator with me on a number of online perimetry projects, which I'll show later on. And what Jessie found when he looked at what are the sources of the carbon footprint of glaucoma care, it was just about all travel. Patients traveling to and from home to the eye clinic. That was the biggest source of carbon. Much, much bigger than the drops and the treatments and the surgeries and the disposables used in clinic. All that stuff was dwarfed by the patient's travel. So if we really are interested in lowering the carbon footprint of glaucoma care, we need to think about how to improve telehealth and make patients travel less, but still get the same quality care. And there are different ways of doing that. And that brings us to home monitoring for glaucoma. Is it possible? Well, I would argue that we're just on the cusp of this, that the technology is emerging and some of it is just about there. And these are exciting times ahead. The next 5 to 10 years will really be defining this and what it looks like. So what are the pros? Well, less travel, which is greener. more frequent testing. So I'm sure, there are some of you that actually want to be assessed more frequently than you actually are. And of course, some patients, probably not the ones on this call, don't want to be tested at all, but that's a different story. I would say all healthcare services around the world are constrained, and I think it's pretty true about public health services like the public hospitals that I work at, both here in Victoria and where I used to work in Sydney, and even private centres, that we just are not coping with our current workloads. So we can't see patients and do the amount of testing as often as we would like. And then on top of that, patients might want to be tested even more. Well, home monitoring allows that. The patient becomes in control. So if you're there at home and you feel, oh, something's not right, my eye feels off, or I feel like my vision's changed, you can do a test right then to reassure yourself. And if there's a problem, use that to sort of get in to see the doctor, as opposed to waiting for your next appointment, which I know does happen. And it's quite unpleasant for patients when they have to wait for weeks when they think there's a problem now. Will home monitoring lead to early detection? I think so. I think as we lower the barriers of access to diagnostic services, we'll detect more cases. And it'll definitely reduce the cost of care, which is so important as we think about this as a nation. We only have a limited healthcare budget. How can we stretch it out to make sure we care for all that we need to care for? Some home monitoring involves expensive machinery, such as the home eye care devices, which we'll talk about. But do they need to be purchased by everyone individually, or can they be shared? Is it reduced accuracy or reliability? Did the testing at home, is that as good quality results as the testing you get at clinic? Now, that's a good question, and I'm doing a lot of research at the moment looking into that. And I think it's not so much that it's less accurate at home, it's more that we need to learn how to interpret the home test results, which is slightly different from in clinic. So that's really interesting. And is it done inaccurately by patients without supervision? And if we ask patients to do the test, will they not do the test? So these are some of the cons to think about. So what is tonometry? Tonometry is checking pressure. I think we're all familiar with checking pressure, but as a lot of you might know, there are devices now that you could buy to check your own pressure at home. Do I recommend you all do this? I wouldn't blanket say that. I would say that most people probably don't need to check their pressure at home. I think regularly with the optometrist or ophthalmologist, say every 6 months, or some patients more frequently, some patients less, depending on what your clinicians tell you. So I don't want to give the message that I think you all should be buying one of these and checking your pressure every couple of weeks. That is not what I'm trying to say. But I do believe that there's a role for this, especially if we are looking to improve telehealth and reduce patient travel to their healthcare centres, which for many of us who live in rural regional Australia, that's a challenge. Now, one challenge of these devices, as I said, they're not cheap, $2,900. Now, there are some of us that is not a problem. Okay, let's be real. But there are many of us where that is a problem, especially in the context of all the other diseases and all the other health issues and other life issues. So how do we deal with that? Well, in our clinic, as I'll talk about later on, we're doing a study where we've got close to 50 patients enrolled who are doing home pressure checks and also home visual field checks using the Ionic system, which I'll introduce soon. And we share the devices, so we can drop them off and pick them up from the eye clinic, or we can even put them in the mail. So I don't think everyone needs to buy one of these. I think we can be clever in sharing. So let's talk about Ionic. As was mentioned before, this is something that I've had the privilege of being involved in right from the outset. It's a system of doing visual field testing on computers or tablets. So a lot of you are familiar with the visual field machine. I know a lot of you don't like it. It's you guys complaining to me about the visual field test that inspired me to develop this. I figured there has to be a better way, a bit more like a computer game that will work on any computer or tablet. And that's why I developed it. And we were right. Patients do enjoy it better when it's done on an app. And not only is it much cheaper for clinicians who don't need to buy those big machines, but also it's very convenient, very enjoyable, quicker, and people could potentially do it at home, opening the door of home glaucoma monitoring. So these are some examples of how the Ionic, the online system, compares to the standard visual field. So you can see they're very similar sorts of printouts. And here's an example of a patient of mine who they got a conventional visual field done at the optometrist. And when they came to my rooms, we did the Ionic, and you can see how similar it is. I've stopped using the big machines. I just exclusively use the Ionic system in my rooms now. And we can also monitor progression over time, just like the big machines, and look if someone's getting worse or not. And there's lots of advantages once you move to online visual field testing. As I said, it's more enjoyable for our patients, and we've got data to back that up. It improves healthcare access. It allows at-home monitoring. It improves clinic flow. So a lot of you, I'm sure, have spent a lot of time waiting in waiting rooms for eye doctors. Now, a lot of the waiting is due to certain bottlenecks. As you're aware, you have to get the vision checked, then you have to do the visual field, then you have to do the scan. And when there's a sequence of events like that, if one of them gets clogged up, that causes backflow. That's like traffic. That's how traffic works. So if we can find and break down the bottlenecks, such as the visual field machine, we've got great clinic flow, and you can open up testing on multiple computers in the practice simultaneously. Plus, patients can do the test at home once they know how to do it, which is not so hard. Patients are in control of their data. They can assess their data, and they can do things like unclick a previous clinician and click on a new clinician if they're moving or if they're dissatisfied with their clinician. They can also share data between their optometrist and ophthalmologist. So there's a lot that you can do. And here's an example of one of our research papers where a cohort of my patients did the test 3 times on 3 different computers and found a very strong correlation. So the point is, you can do it on different computers. And this is how we do it. As you can see, the fixation target is this spinning gold star, while the flickering targets, instead of the tiny white lights that a lot of you are used to on the machines, they're much larger, and they're these sort of flickering contrast-based targets. And the star moves around the screen so that we can keep you at a comfortable viewing distance to ensure that we're checking the full visual field. We find your blind spot so that we know that the user is sitting at the right position, not too close, not too far away. And we use the webcam to monitor the face to make sure the head doesn't move forwards or backwards. And that's how we can do the visual field without the chin rest and the head strap. And the vast majority of my patients say how much more comfortable they find it doing it on a computer. They don't have to put their head in the machine. It's not a strain on their neck. This is common things that I'm hearing.
Your
Here's an
test is
example
about
of how
to
it
begin.
works.
Please close your right eye and look at the star at all times. Press space or click the mouse when the target appears.
And this can be translated. We've already translated into 26 languages. So it's being used around the world. And as I said, we find the user's blind spot initially. And once we find the blind spot, we're good to go.
Move a little closer to the screen.
That's the AI detecting that the person's face had moved back, and it asks them to move forward, and then the test continues. So as I said, we've done a lot of research. This is one of our papers in a cohort of 220 patients. We found that the diagnostic accuracy of the Ionic visual field test is just as good as the big, expensive, bulky machines that you're all familiar with. We also found that 84% of users preferred Ionic to the standard visual field for the reasons that I've described before. And when we used a 10-item questionnaire, most items they found were better. And we looked at the test repeatability. We looked at Ionic in different countries, different cultures. The guy in the red shirt, he's my friend and colleague Tung Huang. He's an ophthalmologist in Vietnam, and I supervised his PhD, and he did his whole PhD on using Ionic in Vietnam. Again, what I was talking before about scalability is a problem in the developing world. They don't have the resources to cope with now, let alone how they're going to do it all in the future. So they see this as a great solution for that. And of course, Africa, we've done a lot of work in Africa. This is my colleague Simon Arunga's clinic, one of his patients. And you can see that, you know, this is what eye clinics look like in Africa. This is a well-funded clinic in Africa. And you can see computers are versatile. If you buy a visual field machine in Africa, chances are in 6 months it's broken down and there's no one to service it. but computers and internet are common. And that's why we're really getting so much traction around the world. We've just completed a study in Nigeria with 389 glaucoma patients, and we had really good correlation between Ionic and the standard visual field, and we're just writing this up for publication in the Journal of Glaucoma. And of course, home study, this is the study that I was doing in collaboration with my colleagues in New Zealand. Unsurprisingly, the test is reliable and accurate at home, similar to what we found in clinic. And these are patients that did it once a week at home over 6 weeks. I'm not suggesting anyone needs to do visual fields once a week at home, but this was more proof of concept that it can actually work. And I want to thank all my patients that have helped me with all this research. They've watched this develop from something I was scratching together on the computer to what it is today, which is a sophisticated deployed product globally, and everyone's very proud of it. So this is where we are today. I've been all around the world: South Africa, India, Ghana, Vietnam. Everywhere we go, we are well received, and it's being used, being taken up. There's also a bit of entrepreneurship in this. Some of you might be from that part of life about business and fundraising, and there's a bit of that. And I've got great members of my board, business people who have family with glaucoma, who care about it, and who have funded this. And we're working together. It's just a very exciting project, and more and more watch this space. So this is one study that I'm doing at the moment, and we're currently enrolling patients. This is sort of a larger home monitoring study. Now, I know this is a bit complicated, but let's break it down. What we're getting a cohort of about 80 patients to do is that they get the traditional testing. So every 6 months every 6 months they get the pressure checked, and once a year they get the visual field done in clinic and the OCT in clinic. But as well as that, they're doing the Ionic home visual field test once a month, and they're also coming in and picking up one of these home eye care devices once every 2 months. And those that live far away, we're mailing it out to them with a reply paid envelope, and they're mailing it back to us. So I see this study as very promising and very exciting, and I see this as potentially the future of eye care, because while this study, we're doing everything. When you do research, you can't just let people test themselves without us checking. The ethical way to do it is we provide the conventional orthodox assessment, which is getting checked every 6 months. But then at the same time, the patients are undergoing this new form of assessment, which is the at-home stuff, which can be done more frequently. And compare the two. Is one missing stuff? Is the other one not missing stuff? Is the home testing picking up change earlier? I can tell you now, yes, we've had a few patients that, based on their home testing, we've brought them back sooner to clinic, and I've done treatment on them, SLT laser, because of findings that we found electronically from their home testing. And if they were just part of the conventional conventional assessment, they would have had to have waited until that 6-month visit for me to detect that. So I can tell already that this provides more careful and more sensitive assessment. And I would argue that it's more sustainable because it has less travel, less cost, less imposition on our patients, and puts the patients in control. Now, one really interesting thing, and I'm sure there are some of you that are quite sort of mathematical, esoteric, and love AI, you might say, well, hang on, the patients are doing the visual field at home. How do you know we're not going to do it all wrong, and we're going to set it up wrong, and we'll get all these crazy results that'll muddy the waters? And that's a very good critique against something like this. And I think it's true. I think when I look at the data, the quality of the testing, both the visual field and the pressure testing, the quality is much better in clinic than at home. All I can say is this is not a fundamental problem. This is a mathematical problem. Once we gather enough data, we can do the mathematics, in particular machine learning and AI, to help us understand what is unwanted noise, what is artifact versus what is true signal. In other words, we just need to recalibrate these conventional systems so that we can truly understand what the data from home means, and then it will be so much better. And just a final thought about the future. What is glaucoma testing going to look like in 20, 30, 40 years? Have we thought about that? And I would say that it will essentially involve a very sophisticated system of AI, where it doesn't just do visual field and pressure, but it also asks questions, has an economic analysis, comes up with a decision tree, and then the doctor only gets involved if there's some kind of alert or flag from the system. But if everything's going fine, then the patient is monitoring themselves. So I'm sure a lot of you go through the experience where every 6 months or every year, you're going in, you're seeing your doctor, you have a pleasant chat, nothing changes, see you next time. Well, if we build the technology, maybe in the decades to come, we can do better, we can be more efficient, and only involve the clinician when there's actually a true problem. Something to think about. So in conclusion, we can manage glaucoma, and we are managing glaucoma today, but there are problems. Carbon footprint, cost, inconvenience for our patients. It's very staff intensive, very equipment intensive, and we're missing a lot of cases. So can we do it better, greener, more efficiently, and cost effectively? That's where I leave, and I open for questions. Thank you.
Thank you, Simon. That was wonderful. As an orthoptist who is used to doing 10 visual fields in a row in a clinic, it's never fun, let alone for the patient. So it's brilliant to be having an option for our glaucoma patients. I've got a question, if I may. At the moment, it's just at the study stage, is it? Or are patients able to now move from ophthalmologist to ophthalmologist, and they do have their baseline measurements ready to go, and they don't have to start again when they swap to a new ophthalmologist?
That's correct. The Ionic system is actually TGA approved as a Class 2 device. So it's not just a study thing. As I said, we've done 26,000 tests by now. The vast majority are in real world testing outside of studies, and people are buying it. People are using it in Australia as well as in many countries around the world. Many clinicians in Australia. So if your ophthalmologist or optometrist isn't using it and they're asking you to do a visual field on a machine, just say, have you heard about Ionic?
Keep up with it. We do have some questions that have come through. When I see my ophthalmologist, I need to do the visual field test in a darkened room. Is this the case for Ionic?
Not so much. So the room lighting is less important. So if you noticed in Ionic, we had a very bright screen and sort of flickering darker targets, while most visual field testing is the opposite. Everything is very dark and the targets are lighter than the background. And that's why we chose to go that way, so that the background lighting is less important. So I'd still encourage people when they're doing it at home to turn the lights off and not have a lamp sort of shining on their computer. But it's been designed so it's to be less affected by background lighting.
Thank you. And another question, does the size of the computer screen make a difference?
It's a good question. So what actually happens is the app in the background measures the size of your computer screen and it resizes the elements accordingly. So in general, the smaller the screen, the targets are sort of all moved closer and smaller to each other, and the user is asked to sit closer. So the smaller the screen, the closer you sit, but you achieve that consistency. And if you remember, I showed you that picture of that gentleman who did it on 3 computers, one big, one small, one intermediate, and he got exactly the same results, and that's why.
So it's all relatively calibrated.
Correct.
To be a uniform result. Thank you. Would I still need to do a visual field in clinic if I'm using Ionic at home?
It's a great question. I feel like we're on the cusp of changing things. So I would say that a lot of clinicians may not accept a home test. I certainly, even I'm very much accepting of Ionic and I use it exclusively. But if someone's done a test at home and I think, oh, that doesn't look right, for some reason they've done it a lot worse, then I would repeat it in clinic. But if they've done a really good quality test at home and I'm confident that it is what it is, then I wouldn't ask them to repeat it in clinic.
Thank you. We have a question from Tan W. Are the inclusion-exclusion criteria available on your website?
Of my studies,
Yeah.
no, because I that was just one study. I've got lots of studies that I'm doing simultaneously. But Tan, if you want to be involved in any of the studies, please let me know. But in terms of inclusion and exclusion for Ionic, for using it sort of outside of studies, there are no specific inclusion or exclusion criteria. The only thing is we just have a warning that because of that spinning gold star, if someone has unstable epilepsy or unstable vertigo, it might set them off a bit. So that's our only health warning.
Thank you. Another question, is there a Medicare rebate for this test, or it's not at that stage yet?
Yep. If you do it in clinic, then you can claim the same item number that you would for a conventional visual field. Now, the great question is there a Medicare rebate for home testing for home visual field? And I would say currently there isn't, but this is something that I feel like Ionic and Glaucoma Australia should work together and aim for that, because I think everyone would benefit. It's just, as a lot of you might know, Medicare is very hard to change, and you can't just sort of come up with new technology and expect Medicare to change overnight. It takes a lot of work and a lot of advocacy to get there, but that's never stopped me in the past.
Forge ahead. We have a question. Where is the data stored? Is it on the laptop, it's on the computer itself, or is it a cloud storage?
It's the cloud. It's all stored in the cloud. And you, the patient, have control by your sort of email control of the data, and you can choose to share it with clinicians or you could not share it. And it's all very sort of cyber secure. We take all that very seriously, and we've worked with Microsoft to develop the system, because obviously today it's all about cyber security and that sort of thing. So you got to take it really seriously, and we do. And that's part of the TGA certification, and we're currently going through something called ISO 27001, which those in the computer industry know that's the standard certification for cybersecurity.
Yeah, fantastic. Here's a response for Maria. Vitamin B3, nicotinamide, has shown neuroprotective potential in glaucoma research, particularly in protecting the optic nerve. However, it's not yet an approved clinical treatment for glaucoma. While studies suggest it may help reduce retinal cell damage, further research is needed to confirm its efficacy and safety. Currently, eye drops, laser therapy, and surgery remain the standard treatments for managing glaucoma. That's a
pretty good answer to the question. What about vitamin B3?
Yeah. Sorry, that was roundabout. So you mentioned that you've trialled it in numerous countries so far. You have 11 research papers. Do you feel that the Australian community is on board?
The Australian community is not, funnily enough, not as far advanced as other parts of, say, Africa and India, purely because it took us a little bit longer to get TGA approval, which only came through 6 months ago. But now that it's there, the Australian community is very quickly getting on board. And there are some things in commercial confidence that I can't say, but there are some very, very large organizations in eye healthcare that are seriously looking into onboarding Ionic as a solution for their patients.
That's fantastic. In the stats that you showed, Simon, there was a 6% noticeable patient data in Africa. How quickly do you think something like this could increase a better diagnosis amongst the glaucoma community?
I don't know. I think it's a great question. And I don't want to oversimplify things by saying glaucoma is not detected in Africa because they don't have visual field machines. That's way too simplistic. Like things like there are complex problems in Africa. But I will tell you something, that right from the word go, Ionic has been collaborating with thought leaders in Africa. And one of my good friends, Professor Olawaye, she's really the doyen of glaucoma in Africa. She's been so supportive. She was the one that got us to do that big study in Nigeria. We just had the World Glaucoma Congress, and there was a symposium on Africa. And there were 4 talks, and we were asked to give a talk, Ionic, Australian Ionic, talking about Africa in the African Symposium. And my friend and colleague, Dr. Deis Bigirimana, who is from Africa but now lives in Melbourne and works with me, I said, you give that talk. This is not my talk to give. This is your talk, because he's been at my side championing Ionic in Africa. So it's a really proud moment for what Australian tech is doing to make a big difference in those parts of the world.
That's fantastic. We have a question from Ujudi. If someone has cataract as well as glaucoma, does Ionic's bright screen still work?
Yeah, it's a good question. So as I said, in my practice, I use Ionic exclusively, and as well as looking after glaucoma, I look after patients with cataract. So I have a lot of patients that have both cataract and glaucoma, and I noticed that those that have cataract can cause sort of false changes on the visual field. And so that is a potential limitation of the software. But again, what I said before about home monitoring is the same, that this is a solvable problem. Once we understand the mathematics more, we'll be able to understand more what is cataract versus what is glaucoma, and improve it over time.
A question from me. What home tonometer do you use for measuring pressure? Which one do you recommend?
So look, I don't like to give endorsements. The one that we're using in the study is the home eye care one, and that's the one that I showed before in the talk. I can't comment on how it is compared to the other home eye care devices. I just don't know enough about that. But I've been very happy working with the home eye care team. They've been very obliging in the study, and they're just great to work with. So yeah. I think we're lucky in Australia that the world of glaucoma is sufficiently small that all the big commercial players, their heart's in the right place, and we all work together. Like clearly, if you're a commercial enterprise, like you need to make $1, that's okay, but there's more to it than that. And so yeah, it's a good space, and Glaucoma Australia does a great job sort of bringing us all together and showing us this is the way you guys should go. This is the direction you guys should work together, and we do.
Thank you, Simon. Yeah, that's fabulous, and we're very close collaborative partners with a number of ophthalmologists and the industry as well. So thank you. Now, just in the essence of time, we don't have time for any more questions. However, if you do have a question that was not able to be answered tonight, can you please direct them to glaucoma@glaucoma.org.au, or you can phone us on 1800 500 880, and we'll forward to Simon for his response. So thank you again, Simon, for such a fabulous presentation and enlightening us on new technology, the way forward. It's a very exciting time to be part of the glaucoma space.
Thanks, Val. I do it for everyone here. You know, I care deeply about my patients and people in Australia with glaucoma.
Thank you. Thank you to everyone who joined for this live webinar tonight as well. And it will also be available on Glaucoma Australia's YouTube channel and easily accessed at the bottom of our GA website homepage. Enjoy the rest of your evening. Thank you.